ladies and gentlemen, dear colleagues, dear friends, it's with great pleasure that I open today, now, the 9th Congress, World Congress on Systemic Sclerosis. And first of all, let me just mention all the colleagues that unfortunately could not make it up to here because they were stuck in other countries due to the war. But however, we should go on, and today is an important day because 16 years ago we started. We started together in Florence, and you see here when we started the foundation together with the first Systemic Sclerosis World Congress. And here you see also the mission statement of the foundation. So in all these years, 16 years now, today we have achieved several tasks, and we hope we should achieve even more in the next future. And you may see here, where are we now? And where are we now? Because you see several items that we have achieved. Some of them are still ongoing up to now, but there are others who are coming up to 2028, when there will be the next Congress. In particular, I would like to remember research projects, and today Professor Krieg will present them one by one. Those who were awarded in 24, the new one in 25 with the young investigator, and all the colleagues that were awarded, those who participated in this Congress. Because we have several activities and projects. You see master classes, you see now the new academy with webinar and podcasts, as well as you see symposia. The ILD symposium that will be now next in January 27. But we have also ad hoc committees. You see here all the colleagues that have shaped up the ad hoc committees and that have made these committees very successful from the scientific point of view. But we have also one of the backbones of the foundation, and is JUSTA. And all the board and councillors have been incredibly helpful to shape up the present and the future of the foundation. And you see how many centers, how many patients, but please notice how many publications that JUSTA has produced in the last 20 years. And I would like also to remember Alyosha, Alexander Clay, that started with us the foundation in 2010 and unfortunately died some years ago. But it's also my distinguished pleasure to call the Grand Dame Professor Karen Black now please to address our colleagues. Please, Karen.
Marco, thank you, and good evening to you all. It's wonderful being a patron because you don't actually do any of the hard work, but you enjoy all the pleasure and privilege of being at an event like this. Marco has just told you of the journey and the growth of WSF, and it is wonderful when I look around and see so many people here, but a wonderful mingling of patients as well as those who look after them. We couldn't do anything without our patients, the reason why we're here, and we know that around the world care is not equal. It is so sadly a postcode lottery. So one of the things that I am passionately interested in being the patron, and I hope you're going to hear at the moment, but we're going to add, so I'm not going to be the only patron. I hope I'm not saying anything, Marco, that I shouldn't be saying. But it is wonderful to have the opportunity to be in a position to advocate for something and to try and spread it around the world so that in countries that are not as fortunate as some of the countries we live in, they too can benefit from education and knowledge and research. I know that we are running behind time, and therefore I should be as short as possible. I just wish you all an incredibly rewarding and interesting conference, and may WSF go from strength to strength. Thank you.
Thank you, Carol. Thank you very much. And we have also now another new patron of the foundation, and it's with great pleasure that I call Professor Dan Furst, that has been a pillar for our community, and please, Dan, it's a real pleasure to have you.
Well, I'm by no means a grand dame, but Carol is an incredible patron for the WSF, and I'm so glad to be joining her. I just wanted to say a few words about one, Athens. You know, it's a great place to see, and you need to spend a little time, what we call in the US, me time, doing some sights and some food in the city. And the Congress itself is really pretty neat. There are multiple systems that are being emphasized. For me, the areas that I think are really super are the new areas in the GI disease, in the cardiovascular system, in biomarkers, and the psychosocial aspects of taking care of our patients. The WSF has been growing. This year has had the greatest number of abstracts submitted that we've ever had. And I think there is something that we've tried this year, and you've got to tell us whether it's going to work or not, which is to get the participation of you, the rheumatologists, who are also going to vote on the best abstracts. So this is a great Congress. And I hope you are looking forward to a great time. Thank you.
Thank you very much indeed, Daniel. And now I would like to call Mrs. Sue Farrington, who is the president of FESCA. And as you may know, we have also in parallel the Congress of the Patient. And Sue is for many years with that.
So, good evening. It is a real honour to be able to say a few words at the opening of this clinical congress in Athens. And it's always an honour to join this community of amazing clinicians, researchers, specialists. Your dedication, curiosity is really driving progress for people living with systemic sclerosis. However, scientific progress in and of itself isn't enough. It must be matched by policies that equip healthcare systems with the capacity and resources to provide equitable care for rare disease patients no matter where they live. And I'm pleased to report that FESCA's commitment to rare disease advocacy over the past few years, particularly within the scleroderma community, has positioned us as a trusted and influential voice. As many of you know, our work spans targeted awareness, evidence-based surveys, working with patients, and we've increasingly been engaging with MPs, MEPs, and policymakers. As a result of our credibility and expertise, it's been formally recognised, and we've been invited to contribute to the Santé Committee's report on the development of a rare disease action plan. This is something that the community has been championing for many years, and it looks like we may finally achieve it. Tomorrow, as Marco said, we'll open the patient conference, but tonight it's about you, the scientific and clinical community whose work continues to transform what's possible for patients across the world. At FESCA, we've spent the last few years spending a lot of time listening to what patients have told us about their desires and hopes. Their message is clear: earlier diagnosis, better access to treatments, more coordinated care. But equally important, they want a stronger bridge between the scientific world and their lived experience. And that bridge begins here with you. So as you gather this evening and throughout the Congress, I really encourage you to carry the patient voice into every discussion, every debate, every new idea. Scientific knowledge advances the field, but it's the partnership between the learned experience and the lived experience that ultimately improves lives. On behalf of the patient community, thank you. Thank you for your work, your innovation, and your unwavering commitment to improving care for systemic sclerosis. I wish you all a productive and stimulating Congress, and if any of you do have the time, then please come and join us at the patient conference. Thank you.
And it's now really a pleasure to call Professor Ronald Agiu, who is the Dean of the School of Health Science at the National and Capodistria University in the city of Athens. Please, welcome him.
Okay, dear colleagues, distinguished guests, I would like to thank the organizing committee and in particular my good friend, my new good friend, Professor Matucci, and my old good friend, Professor Petros Spikakis, for their kind invitation to address this prestigious event. As Professor Matucci told you, I'm here in my capacity as Dean of the School of Health Sciences, representing the National and Capodistria University of Athens. And just to give you an idea of who we are, for those of you who have traveled internationally, our university is the oldest higher education institution in Greece and the first university that was established in the Eastern Mediterranean region. It amalgamates 185 years of tradition with innovation. And its School of Medicine, under the auspices of which this Congress takes place, is by far the biggest department of the university. It ranks very highly among international institutions in several classification systems, and this achievement is a reflection of the university's academic performance and research accomplishments. To get back to the Congress, I'm not sure if Professor Spikakis has mentioned to you that systematic sclerosis and scleroderma are all Greek words. Other than that, I had the opportunity to browse the program, and the effort and the science is truly international. The Congress brings together leading clinicians, researchers, and most importantly, patients from around the globe who share a common commitment to advancing the understanding and management of systematic sclerosis. The program is indeed impressive. It addresses the latest scientific discoveries, innovative treatment approaches, and emerging challenges in the field. I invite you to take full advantage of the diverse sessions and networking opportunities to connect with peers and experts. But equally important, in between sessions, please make sure to steal some time to relax and enjoy the main historical sites of our city. I think the weather is cooperating. I'm really sorry to hear that due to the international situation, some of the attendees had to cancel their participation, but please do take advantage of the city. I'm confident that your active participation will contribute to the broader mission of improving the lives of patients affected by systematic sclerosis worldwide. Welcome, and I wish every success to the work of this Congress. Thank you very much.
So here you see how many participants we had up to some minutes ago. So we are at 1,060, and from 56 countries. We'll see how many will come and will arrive still. I have to say that we decided rapidly to put the Congress on streaming so that there will be those who could not make it. They are following us still on the streaming band, and at least they can participate with us even on the screen. And our sponsors, in particular Boehringer Ingelheim, is a platinum sponsor, and the gold BMS and MSD, and the silver AstraZeneca and Argenx, as well as our sponsors bronze, AbbVie, Cabaletta, GSK, Novartis, and also the exhibitors, the Scleroderma Forum, Formosa, and the hosts. And I would like now to call just a few seconds Professor Nobuta Kuwana, who is the editor of the JSRD, and I hope he's here. If we can join me. Do we have Marcel? Please. And he will just tell you something about the journal, because the journal has a new life. Please, Marcel.
On behalf of the editor board of JSRD, we are happy to announce that we transferred the publisher to BMJ, and I think this will result in the increased quality of the journal, and one of the mission of the WSF is to promote the high quality of science. So the JSRD will contribute to this mission. And I discussed with the Marco, the co-editor chief. This is the first time to announce the best reviewer award. So we announced that the Professor Virginia Steen is selected as the best reviewer for the JSRD. Congratulations.
Jimmy, I'm sorry, we could not resist. So you have to excuse us, but thank you very much for contributing so really with such a passion and devotion to the journal. Thank you very much, Jimmy. Thank you. Now we arrive to these days, and this new program and project that we had with Chances of Progress, because we thought we're coming to Athens, let's compete. Let's compete, and that's the reason why we thought that you will see the awards later, and Professor Grigg will present the awards, but we thought also that it's correct that to take all the participants that are here together with us to participate all together to say what are the best posters. So that's the reason why we are preparing now here the Champions of Progress. So, and when you will go in the poster areas, there will be some totems, and I would beg you please to vote for the best abstract, poster that you have seen, because when you arrive here, you will see, you explore the poster, then you can scan the code and vote for your favorite poster, for your favorite research. So all of you will participate. And at the end, and the closure ceremony, we shall announce who will be the winners, and the winners together, they will take the torch, will be the torch bearer until Florence 2028, because the next time, in 2028, we shall be in Florence. So we are going back where we started, and our colleagues who will be the winner, they will be given the torch, and they will take the torch, and then they will open the next Congress in Florence. So now, let me enter into a dream. Let me enter in what has been, for all of us, a significant challenge. A significant challenge that has characterized our life. Because we always thought, how can we best serve our patient and make scleroderma known to the people, to everybody? And from this, the foundation started to think about Advocacy. And here you see the soul struggle. This is what we have and what we are preparing now, because these statements that come from these three artists, you see at the top is Leonardo, in the middle is Michelangelo, and below is Renoir. And you see what they are saying. The first two had osteoarthritis, Renoir had rheumatoid arthritis. But despite this, despite the disease, despite the age and all the sufferings they had, they were able to paint and to transmit to us their legacy, but in particular, Paul Klee. Paul Klee, that is our light, and the family Klee has been the partner, as you have seen, of the foundation, and we always go back to him, that died tragically of scleroderma. My body bends every day a little more, but my mind flies, and in the dreams, I trace, I am free. So we thought that we should not forget, in particular Paul Klee, but also the others. The others will help us to build our case and to present the case to the public. And when you exit here, you will see there is a booth, WSF booth. You can see a part of the trailer. You will see the trailer now, Beauty Beyond the Limit. And it is my pleasure now to ask if they can start with the trailer, please.
Leonardo da Vinci. Take one. When I was creating, I felt pain in my fingers, but a greater force pushed me beyond. Something that surpassed that pain. Because art has always been a necessity for me, as I felt my soul in struggle.
Rheumatic diseases affect the human body, bringing pain, stiffness, and disability. Osteoarthritis deforms the fingers, making even the simplest movement difficult. Rheumatoid arthritis inflames the joints, turning every gesture into a painful effort. Scleroderma, the most severe among the rare connective tissue diseases, tightens the skin, bends the fingers, and slowly takes freedom away from the body. Today, more than 2.5 million people worldwide live with this condition. So what if we could go back in time and ask one question to the greatest minds in history? A simple question, a timeless one.
How did you create beauty while your body was breaking down? I've created beauty by thinking beyond the pain, by letting thought take flight when flesh could not. My body betrayed me, but beauty gave me a reason to keep moving and painting. As my body fell down, crippled. I painted what could still be felt. I've carved my pain into stone until it took the shape of beauty.
4 geniuses, 4 wounded bodies, 1 unbreakable force, art. But today we have something they did not. Knowledge, research, and hope. Scleroderma can be faced, and one day it will be defeated.
With what we know and what you know, together we can beat scleroderma and inflammatory and degenerative joint diseases. Never stop supporting research. Never.
Soul in his throat, trapped inside a body.
So thank you for projecting this trailer. I'm sorry, this is very short. There is much more to be seen, obviously. But for you to know that the premiere will be in Venice, October the 17th, 2026. And you may see this is the video where usually movies are projected. We shall be all there. So when you exit, please record yourself, register yourself, and we look forward to having you all together with us for this sensational event that is unique and is the first time that this movie will come out, first of all in Amazon Prime, and then probably will be also projected in several countries and with all events organized on top of it. So please come and stay with us. And now I would like to introduce Professor Thomas Creek, that will take the lead of this opening, and he will continue with all the research part. Please, Thomas. Thank you very much.
Good evening, ladies and gentlemen. It's the aim of a foundation like the WSF not to store money, but to provide help to researchers, to create knowledge and to help the patients. And therefore, we have created the grant system, which works on many different levels. And I have the pleasure to introduce you to some of the winners of those grants which we have given during the last year. Let me start with the junior research grants. And in the year 2025, we have been awarded 5 different junior research grants, which have a different topic. Each has a different topic, which is coming together with €30,000 for each winner. And you can read the winners here. It goes through different countries and different areas. And I hope that these junior research grants, they really help the researchers to get started to apply for larger grants in the years to come. The next grants which we have given have been 2 major grants on interstitial lung disease, research on interstitial lung disease, and we have given these grants in 2024. And these grants go to Cynthia Ferris and Julie Morel. And because one of the conditions within these grants was that we wanted to hear here some of the success of this, I must say, early success of some of the results, I would like to ask now to first Cynthia Ferris from the Netherlands to come up and just summarize the main results of this short term she had already spent on. There's Cynthia.
Thank you. I would first of all like to thank the WSF for obtaining this grant. And I would like to give like a short update on the project, which focused on the topoisomerase 1 antibody response and how it might lead to the development or progression of interstitial lung disease. Yes, so briefly, we and others have shown that the anti-topoisomerase antibody response associates with a poor prognosis and interstitial lung disease. In addition, we also know that B-cell responses are involved in the pathogenesis of scleroderma, as B-cell depleting strategies are effective, here shown for CD19 CAR T-cell therapy. And moreover, our lab has shown that autoreactive, antigen-specific anti-topoisomerase B cells specifically also correlate to the extent of lung fibrosis. And therefore, we kind of hypothesized that the anti-topoisomerase antibody B cell response could be a dynamic driver of disease activity in systemic sclerosis. And this leads to the aim of our research, which was to understand the role of the anti-topoisomerase antibody B cell response in the development and progression of ALD. And to this end, we actually developed two technologies. The one is a mass spectrometry-based approach to measure specific fat domains of antibodies of the anti-topoisomerase response, and we will do this in serum of patients who have and have not ALD. And we also have serum available of patients at the moment that they actually start to develop ALD. And then the update is that we currently are able to very specifically capture the specific anti-topoisomerase antibodies, and that we can process them to individual fat domains, allowing us to actually profile individual profiles within the patient and see whether they could be a biomarker for development of ALD or progression of ALD. The second technology aims to characterize the B cells themselves. And in the last years, we actually developed the technology to capture those antigen-specific topoisomerase reactive cells, specifically in the blood of patients. And then we already know now that the phenotype of those cells is a highly activated one and a proliferative one, based on, for instance, elevated markers of CD80 and CD86. And then we will also now measure and quantify this response in patients with and without topoisomerase. So with that, actually the outlook of the project is to obtain detailed molecular insights of the makeup of the topoisomerase 1 B cell response and autoantibody response in relation to ALD development and progression. I would also like to achieve more understanding of the clinical heterogeneity of those patients, and then later on to actually use this knowledge as a kind of instrument to better stratify or identify the patients that are at need for more aggressive therapies. So with that, very briefly my acknowledgements. Most work up to now has been done by PhD student Sam Neppelenbroek, and currently the work is being done by postdoc Theo Papadimitriou. Thank you.
So thank you very much. Unfortunately, we have not planned to have a discussion here on this results, but Cynthia will be available during the welcome reception, so this is a good opportunity. The second grant has been given then to Julie Borrell from the University College Dublin. And Julie, could you come up?
Hi, I would. Oh, I've gone the wrong way. No, I'm on the ground. Green. Sorry about that, everybody. I have now learned how to use the pointer. I would like to thank the organisers and also the World Scleroderma Foundation for funding this work. So my study focuses on fibroblast trained immunity, or the idea maybe that these cells can do this process. So I hypothesize that this fibroblast trained immunity is driven by the release of pro-inflammatory cytokines, and this in turn will drive lung fibrosis, and that potentially this represents a viable therapeutic strategy in systemic sclerosis interstitial lung disease. We know that this process is really important in terms of resolving acute infection, but when it becomes dysregulated, it can amplify the immunopathology in chronic lung conditions. Specifically, we know this is important in myeloid cells, but what about the fibroblast? Well, Hopefully, I'll be able to determine how this pro-inflammatory cytokine-induced fibroblast-trained immunity might contribute to lung fibrosis, identify the distribution and function of these pathogenically altered cells in vivo, and then assess how disrupting these interactions and dysfunctions might influence the fibrotic niche. So, preliminary results indicate that pulmonary fibroblasts do not return to their resting state post-treatment with cytokines or TGF-beta. So in this instance, fibroblasts are treated in vitro for 72 hours with a pro-inflammatory stimulus or TGF-beta, thus mimicking encounters that someone would experience in vivo, like infection or inflammation. The fibroblasts are then rested for 24 hours, so the stimulus is withdrawn. And what you can appreciate from these graphs is basically that these fibroblasts do not return to their baseline or resting state. So this shows that there is prolonged functional alteration in these cells even after the stimulus has been withdrawn. We can see elevated levels of IL-6, IL-1 beta, and CXCL10, possibly indicating enhanced functional responses, one of the hallmarks of trained immunity. So these fibroblasts may exist in a prime state and may respond more rapidly following a subsequent injury. What might this mean for their microenvironmental interactions with immune cells? Well, when PBMCs from control patients are cultured with the supernatants from the arrested fibroblasts, we can appreciate that at both 3 and 24 hours, we see activation of the immune response. Specifically, and in the interest of time, I'll just mention T cells. So at 3 hours post-co-culture, we can see upregulation in all stimuli conditions of CD71, a marker of metabolic activation and proliferation in T cells. This metabolic activation or enhancement persists in the TGF-beta group up to 24 hours, suggesting that these inflammatory fibroblasts or these trained fibroblasts might promote rapid immune cell activation in the lung microenvironment. This leads us to another question, which I'll explain very briefly. So potentially, might there be a master regulator or a switch that we can turn on or off to potentially therapeutically target this? So many years ago now, we identified REL, an NF-kappa B signaling family member, as a master regulator of fibroblast extracellular matrix protein production and proliferation. We found that REL was expressed at high levels in the systemic sclerosis zone, particularly in fibroblastic foci and in local immune cells. REL also has a role in fibroblast immune cell crosstalk, which I don't have time to talk about today, but if you'd like, you can hang out with me at poster 79. Very briefly, treating fibroblasts in the skin with the CREL inhibitor REL reduces their expression of pro-fibrotic genes in response to TGF-beta stimulation, so affecting this transcriptional phenotype. Additionally, in primary human lung fibroblasts, treatment with the REL inhibitor will alter metabolic activation and proliferation. So showing that again, this REL inhibition can target additionally another hallmark of trained immunity, metabolic activation. And finally, I would like to thank all of the people who helped with the study. It's very collaborative and it's still ongoing, so you can also chat to me afterwards. Thank you very much.
Thank you very much, and also usually you will be available for discussions during the welcome sessions. Last year, the advisory board has also come together and decided on the 2025 large grants. And to get this next slide here, I can announce that we have given 2 grants, large grants on interstitial lung disease. One is going to Dr. Corrado Campiosciaro from Milano, and one is going to the United States to Robert Lafayette. And I think everybody knows these people, and we congratulate you for getting these prizes, these grants, and we also hope that in 2 years we can hear some of the preliminary results coming out from those starting grants for new research areas. So congratulations. Also then certainly started at this, giving a number of tries, getting initiatives to start new work, and get maybe in 2 years the application for a major grant to the WSF or another grant organization. So this was a summary of the different awards and prizes the WSF has been giving, and I hope that you recognize that the WSF is really using the resources which come in to really make use of them for encouraging young people to stay in to come to the field, to stay in the field, and really create something new knowledge. And at that point, I can handle the chair over to Yannick Alano and Dan First, who will chair the next session. I thank you for your attention.
And so we proceed onward. We have three very good speakers. The first speaker is Ginny Steen, and Ginny has been instrumental in a great deal of clinical research for a number of years, and now she's doing her bit to help patients move forward. Ginny? And okay, and what she's going to do is move forward with her clinical research in a year in clinical review. Oh, by the way, we are half an hour late, so we're going to have this hook that we're going to pull if you go over.
Thank you, and thank you very much for the organizers for inviting me to share this talk with you. And this is, I think, although I wasn't given any direction, is really to share what I feel is the most important things that have happened over the past 2 years. I can just click, no? Okay, which one of these do you do? Anybody have any help? Nothing seems to do anything.
I have no idea what.
You can push the same buttons I can push. That's not right.
Okay, the next word is hello. Can we have someone with technical knowledge of this very complex box? That's not it.
It's not it either.
I think we need a technical support. If someone could come to help us, we need the slide from Professor Virginia Steen.
No, that's not Virginia's.
Just for everybody's knowledge, this is Virginia Steen. Just again, hang in there, folks, but there is someone who came in and hopefully knows what the heck they're doing. So, and Ginny assured me that unfortunately she actually needs data. We won't take this off your time.
Well, I can just talk. What I'm going to talk about today is several different areas that have made a good bit of progress over the last couple of years. First of all, many of you know that I've been involved in autoantibodies and precision medicine in a long time. We're going to talk a little bit about that. And then how clinical studies and evaluations of organ systems, which one I've felt has been most important. And then finally, some of the new treatments that we've been benefiting from as often as we have from other diseases in which have included scleroderma. And finally, talk a little bit about the future of what future therapies would be.
While they're while they're trying to do their job back there, let's ask if your Distler can come up and give us part of his talk with the hope that in fact his slide will come up.
I was really nervous until I saw my first slide, so thank you for having me. I'm actually supposed to summarize the basic science of the last 2 years and the highlights. You can imagine that this is really a difficult task because science in scleroderma, including basic science, is really growing so rapidly and getting better and better. So over the 20 years that I'm witnessing, I think the task of summarizing the highlights became harder and harder. So what do you do with... Okay, I have the first slide, but I actually can't move the slides. I think there are just 2 buttons. None of the buttons actually works, so may not be on me. Oh, yeah. Okay, so apologies. Now it's actually moving. But what do you do with a difficult task? You actually ask friends to help you and to help selecting and proposing publications that might qualify for such a summary. So I'm very grateful to Carol, Chris, Sherwin, and John for support in selecting and suggesting publications over the last 2 years. On the other hand, if you have problems with the selection that we made, feel free to address it also to those people here, not just to me, of course. So you may have witnessed the progress, in particular the technical progress in omics technologies over the last couple of years. So half of what you hear now in the next 15 minutes or so is about omics technologies. So I simply summarized it into 2 categories, one being omics and the rest being others. So apologies for those that don't like omics, because the next couple of minutes I will feed you with quite some omics publications. So the first publication I would like to highlight is from the Japanese group here. It deals in particular with classical single-cell RNA sequencing with a focus on circulating immune cells, asking the question, can I identify populations that may predict or at least correlate with certain disease outcomes? And here's the overview of the study. So 20 plus scleroderma patients undergoing single-cell sequencing, and some of that confirmed with spatial technology. Again, the focus was on circulating PBMCs, and some of the results has been confirmed in tissue. But for today, I would focus actually on the circulating PBMCs. And the first figure that I got interested in was actually this one here. This compares the ratio of different circulating immune cell populations, on the left side myeloid cells and on the right side lymphoid cells, in scleroderma versus healthy. And it's a small figure, I know, but if you're searching for a significant star, there is actually none. So none of those populations was significantly deregulated. And at that point, I was slightly surprised, but I kept on reading and was absolutely worth it, because when they actually compared within scleroderma subpopulations defined by clinical manifestations, they were able to sort out populations that correlate, in that first case, with scleroderma renal crisis. So what you see on the top is a so-called UMAP visualization on the left side with patients with scleroderma renal crisis, on the right side patients with scleroderma but without scleroderma renal crisis. And every color encodes a certain population of cells. You may appreciate that the red population in the middle is virtually only present in patients that have scleroderma renal crisis, but not in those without. This is a population of CD14 positive, ERAC positive monocytic cells. If you want that quantified in a bar graph, in a box plot, this is shown here, so a significant upregulation of this specific population of monocytes expressing high levels of the transcription factor EGR1 in patients with scleroderma renal crisis as compared to those without. Also quantified here versus other diseases with renal involvement, so lupus nephritis, MPA, and again healthy controls, showing that the upregulation in terms of numbers of that population is specific to scleroderma renal crisis. Moreover, the quantified expression levels over time in patients with scleroderma renal crisis. So you see the first spike is actually before, then after onset, and this long-term follow-up, and you can appreciate that the expression number of those cells rises with the onset of scleroderma renal crisis. It slightly decreases over time. They are also functionally profiled those cells, showing that they are actually active pro-inflammatory cells with interferon signaling, TNF signaling, to name just a few, and a bunch of transcription factors, including REL-A, amongst other NF-kappa-B-related transcription factors. So a new pro-inflammatory population that is highly and specifically upregulated in scleroderma renal crisis, at least in that first population. So biomarker potential here after some confirmatory studies. But actually they didn't focus only on the kidney and scleroderma renal crisis, but also on other manifestations, and were able to identify another population, this time increased in scleroderma-related ILD as compared to patients with SSC without scleroderma-related ILD. This is now the orange population of CD8 positive TEM cells that express high levels of ISGs, or interferon-stimulated genes, that again is significantly increased in patients with ILD as compared to those without. Also here the quantification showing an upregulation, a confirmation on a different experimental level that those cells are indeed increased in those patients with ILD as compared to healthy controls as well. And a functional profiling, again highlighting that those are classical pro-inflammatory cells driving interferon response amongst other pro-inflammatory pathways. So both of those cells might have potential to indicate and identify certain populations of risk of scleroderma manifestations with high morbidity and mortality. Another fantastic publication, both technically and content-wise, is from Johan Gudjonsson's group and the Michigan group in general. They were the first actually to use a spatial omics approach in scleroderma. This is a so-called Visium approach, where you take small areas of a tissue and isolate them and perform deep sequencing of that area. At those times, it was not at single cell level, but rather a couple of cells that are sequenced, but you can use bioinformatical approaches to bulk those cells and then conclude on the spatial profiling of those cells within different niches in the tissue. You see on the right side, again, a UMAP visualization, that this technology is really able to capture all the different cell types that we think of in the pathogenesis of scleroderma. So focusing now on fibroblasts, that's again a UMAP visualization on the left side showing you the different populations. Each population is a different color, and in the middle you see actually the comparison of scleroderma versus healthy. scleroderma being red dots and healthy being blue dots, showing clear shifts in particular in those populations here. Those populations, the SFRP2 positive fibroblasts, have been described before by Bob Lafiatis and his group as disease-promoting precursors of myofibroblasts, but this work added on to show that actually collagen 8 expressing cells are fairly specific to scleroderma, virtually not found in healthy tissue, and that those might be actually a differentiation stage close to myofibroblasts, starting from the SFRP2 positive fibroblasts. This is shown here. If you focus on these three different cells that I highlighted before, the collagen 8 positive cells have the highest extracellular matrix score, the highest TGF-beta score, and the highest IL-4 score, highlighting that those cells are really key effector cells, but eventually also disease-promoting by release and signaling via cytokine pathways. On the right side, you see a differentiation trajectory suggesting that they really differentiate into the mature profibrotic state of a collagen 8 positive fibroblast. There's additional work with other spatially encoded technologies that I don't have time to go into, but just for the sake of completeness, this is a technology that is now at single-cell level, so cyclic in situ hybridization. But the disadvantage of that technology is that the depth of profiling, so the amount of genes it can detect, is lower as compared to the previous one. So maybe both might be complementary, providing depth of sequencing, but also high resolution in single-cell phenotyping. However, I would like to continue with Johan Gudjonsson's paper, because he didn't focus on fibroblasts only, he also did major work on endothelial cells using his technology. And again, I would like to highlight one particular population encircled here that is highly upregulated in scleroderma as compared to healthy control. What population is that? That's actually a population of endothelial cells expressing markers of fibroblasts such as alpha SMA. So a state in which endothelial cells undergo fibroblast or myofibroblast-like transformation and MT as described by Marco, but also by many other groups in the room. Johan and his group went on to show that those cells are actually dependent on the Hippo pathway, a developmental pathway implicated in early embryonic development, obviously reactivated in scleroderma, as for example wind and hedgehog signaling as well. So if you actually inhibit that pathway, you block the expression of fibroblast markers, and those endothelial cells return to a more endothelial-like and a less fibroblast-like state. Another work, this time from Minray, together with my group, so Shanghai and Erlangen/Düsseldorf, was using this time a spatial proteomics approach. So far we were talking about RNA, but now we are using an antibody technology to profile the different populations of cells in the skin, this time with a focus on vascular cells. So this technology allows you to include around 50 different markers, so antibodies that are labeled with rare metal isotopes, therefore virtually have no overlap and allow you to really fine-tune the signal and show co-expression in a single-cell resolution manner. And using that approach, Minray was actually able to identify seven different populations of endothelial cells. Again, each population encoded by a different color on the left side. If you look towards the middle, you see the code blue being scleroderma and red being healthy, again showing that there is a major shift in endothelial cell populations in scleroderma skin. If you quantify the different populations, which is shown here, two populations were deregulated, one being endothelial precursor cells. There is a lot of data on endothelial precursor cells from Yannick, from Marco, and many others in the room, so those data are confirmed by that approach. But in addition, Minray was able to define a novel population of cells, again, endothelial cells expressing CD34, so a precursor marker, and expressing many fibroblast genes. So evidence that there's redifferentiation from an endothelial cell into a matrix producing fibroblast-like cell in scleroderma. And just some nice images here with the different proteomics technologies, this time codecs. You can see that those cells will not only expressing fibroblast markers, but also many transcription factors that promote the differentiation from an endothelial cell phenotype to a more fibroblast-like phenotype. And importantly, those cells were not just around and occurred at certain numbers, but they also correlated with clinical outcome. And actually, they didn't correlate with vascular events of scleroderma, but they correlated with the risk of progressive fibrotic remodeling, in particular of the skin, highlighting that those cells might be functionally important in driving fibrotic tissue remodeling. So now enough for the omics, and for the last couple of minutes, other highlights of the last 2 years. First, I would like to highlight this publication here from Carol Figali's group, which was really intriguing to me because it showed for the first time that mutagenesis and chromosomal instability really shape the somatic genomes in systemic sclerosis. So what Carol did, she used scleroderma biopsies from healthy individuals and SSC patients, so lung explants, I should say. She isolated fibroblasts, and then she actually did single-cell isolation. So each fibroblast was proliferating on its own, generating clones of fibroblasts. And then she did whole genome sequencing to identify potential genomic mutations. And a very complicated and rich paper because they looked at many different genetic changes in scleroderma. So for the sake of time, I'm just highlighting single base mutations on the top and chromosomal instabilities. All of that was significantly increased in scleroderma, okay, small sample size, but very convincing effects as compared to lungs of healthy individuals. So single base substitutions increased, chromosomal instability increased, all of that really accumulated and may contribute to the activated phenotype of fibroblasts in scleroderma. Another publication is actually available as a preprint, but I thought I would really love to share that because I think it's a very novel and groundbreaking concept. Some of us have been working in the field of nerve-fibroblast interactions, but this paper here from Eric Herzog's group is really taking it to the next level and beyond. It's a wonderful causal and functional study on how nerves, and in particular the sympathetic nerve system, may activate fibroblasts to promote fibrosis. So those wonderful images here are from bleomycin-induced fibrosis in mice, bleomycin-induced pulmonary fibrosis in mice. And I hear some of you that may say, okay, everything works in bleomycin, but I will share human data later on. So on top you see vehicle-treated mice, and on the bottom you see mice challenged with bleomycin. And red encodes actually for tyrosine hydroxylase, so the rate-limiting enzyme for catecholamine synthesis. And you can appreciate that there's a really massive upregulation of that enzyme in fibrotic lungs as compared to non-fibrotic lungs, to some extent co-localizing the expression of alpha SMA, so a classical myofibroblast marker. So yes, the pathway seems to be upregulated in fibrotic conditions. But we also actually went on to isolate sympathetic nerve cells. That's what you see on the top, and they co-cultured it with fibroblasts and asked the question, if I co-culture my fibroblasts with those nerve cells, do I render them more susceptible to fibrotic stimuli? And this is shown on the right side. So both without external stimulation and in the presence of TGF-beta, fibroblasts produced more alpha SMA, so differentiated more into myofibroblasts, if nerve cells were around, suggesting that the nerves can prime fibroblasts to differentiate into myofibroblasts and promote fibrosis. This is also summarized here. So if you co-culture again the neurons, in that case of healthy fibroblasts, with neurons, you promote fibrotic activation of those cells. Then they went on with a series of complicated in vivo experiments. On top is an experiment where they used mice that don't have sympathetic nerves, and again challenged with bleomycin. You can see on the histology that the mice with the sympathetic nerve system on the left side which much worse as the mice without, again providing evidence that sympathetic nerve-derived signals promote fibrotic remodeling. On the bottom is a different, more selective approach. This time they were not depleting the nerves, but were actually inhibiting a receptor, the so-called ADRA1D receptor, so an adrenergic receptor that is expressed on fibroblasts. And if you delete this receptor from fibroblasts, again, the mice are less susceptible to profibrotic stimuli. I promised you to present human data as well, so here we go. On the left side, you see the expression of that particular receptor in normal lungs. In the middle, you see scleroderma-related interstitial lung disease. On the right side, you see IPF, and those results are quantified on the right side in the bar graph. You can appreciate that there are more alpha SMA positive cells expressing the receptor in the fibrotic conditions as compared to healthy, suggesting that this mechanism might be operative not only in mice but also in human interstitial lung diseases. And they provided further evidence here using so-called precision-cut lung slices. So you take fresh lung explants, you cut those into thick tissue slices, and then you expose it, in that case, to a profibrotic cocktail, plus minus the alpha blocker terazosin. And again, you can appreciate that in that human setting, with human tissue, if you block the adrenergic signaling with the alpha blocker, you do get less differentiation of resting fibroblasts into myofibroblasts. And now actually time is over, and I'm just finishing with my very last slide, so the summary. Great science over the last 2 years, and I apologize for all the fantastic publications that I was not able to mention, or respectively the authors of the publications. But I was focusing on novel omics technologies that are more and more widely used in scleroderma, that allow us to identify novel cellular subpopulation and characterize their microenvironment, so we might be able to tackle individual subpopulation of cells in the future. We discussed accumulation of DNA damage and somatic mutations in SSC and how that may promote disease. And finally, the new and I think very exciting nerve fibroblast axis that might drive fibrosis. So thank you very much for your attention, and I hope you enjoyed the talk.
Thank you very much, Jo, for the outstanding presentation. And now, I think we can get back to Ginny Steen. And Ginny's been very, very good.
There we go. Okay. So these are my disclosures. And these are the objectives that we already sort of mentioned. So precision medicine has been one of my interests for a long time, autoantibodies particularly. And unfortunately, really hasn't been a whole lot new in autoantibodies. We've known for a while that POL3 was associated with malignancy, and recent work by Ami Shah at Hopkins has shown now that an isolated row 52 has also been associated with cancer in scleroderma. So that's something new. Biomarkers, we've all been wanting desperately to have biomarkers for scleroderma, ILD, and CRP, which is one of the easiest one to get. It's just been very challenging because it's not very high. When we talk about CRP, we're talking about just a little bit of an elevation. We've used CXCL, and KL6 has really been the one that we've really thought has been most important. And recent work by Liz Volkman that has validated this once again in most of the SLS studies. But the challenge, at least in the US, is there still isn't a patented KL6 assay for us to use clinically. Gene expressions on skin biopsy we've been hearing about from Mike Whitfield for years and years and years, and we've been trying to figure it out for years. And really wasn't until Christina Clark came around and really helped us really understand that these do have clinical meanings and associations with disease. But one new paper that I thought was sort of interesting and might potentially be very practical was by Kim Lacken. And Kim and her group were able to do skin biopsies with fibroblast markers that just very specific ones. And I thought that this would be very great to predict whether somebody's going to have a good outcome or a bad outcome. And if we just do a simple biopsy with these markers and get it done the next day, perhaps that might be something that would really lead us to better treatment for our patients. So, clinical manifestations of scleroderma, we've been working on this for a very, very long time. Raynaud's, as you in Europe and Asia have drugs that have been approved for Raynaud's, but we in the United States still have no drugs that have been approved. So we've been working on other aspects, and John Colley and Robin Domsick have been working hard getting the patient-reported outcome, ASRAP, which has now been validated as well. And that's hopefully going to lead to some new studies and new approval of drugs for Raynaud's. GI has been our bugaboo for years and years and years, and it seems like any time we would get a drug that would be approved, they'd either pull it off the market or say it had some horrible black box warning that we couldn't use. And we've had several investigators that have really been going through the literature and doing systematic reviews, and Susanna McMahon and Mike Hughes have really done a wonderful job looking at all of the GI manifestations over, all the systematic reviews of these. And hopefully that will stimulate a lot of new people to work in GI scleroderma, which we desperately need. Interstitial lung disease. Last time at this meeting, Dr. Mays reported on the ATS guidelines. Now the ACR guidelines have become available. This has really been a guidelines for treatment of all systemic autoimmune rheumatic diseases. And so these are first-line therapy and progression, or what is by the pulmonologist called progressive pulmonary fibrosis. And they're pretty much all the drugs that we have available. So it wasn't a real refined thing. The biggest thing they did was to have strong evidence not to use systemic corticosteroids. The second line, as far as progression, we don't have a lot of data, particularly on tocilizumab, on late disease, on combination therapy. And so that's an area where we really do need a lot more information. We've certainly heard about the fantastic results with the early disease without any other medications that we saw with tocilizumab in early ILD. So the other area has been with cardiac involvement. And I think this is an area that we really have found a passion, I would say, from a lot of investigators. We heard a lovely talk from Dr. DeLuca earlier, and something that I'm talking about is from his works. But cardiac disease has really been an enigma. I years and years ago did a study using thallium scanning, and we were trying to find out who had scleroderma heart involvement at the time. But it's not just one type of heart involvement. I mean, you can have inflammatory, you can have myocarditis, you can have pericarditis, you can have diastolic dysfunction. And as we heard, how do you tell the difference between diastolic dysfunction and scleroderma versus all the other things that cause diastolic dysfunction? You can have valvular heart disease, and there are concerns that some of now the aortic valve calcification, maybe that's more of a specific problem in scleroderma. And as well as all the arrhythmias that sometimes mean a lot and sometimes they don't mean a lot. So that's been very challenging. There's so many different things there. One thing that's been very important is the SCTC classification criteria for primary scleroderma heart involvement, led by Laura Ross and her group. And this is, as many of our classification criteria, is a listing of all the different things and a point system. But the first and most important thing is you have to rule in that they have scleroderma, and then rule out all the other aspects of different kinds of diseases, including typical ischemic heart disease and even amyloid and cardiac sarcoidosis. Those are all things that need to be ruled out. And then they go through a whole list of different procedures, starting out with biopsies, and they give different numbers or points that you can get for abnormalities on biopsy, on cardiac MRI, on echocardiogram, on electrocardiogram, on symptoms. Really, it's a very thorough, all based on literature research of coming up with this score. If you have a score greater than 11, it's felt to be primary scleroderma heart disease. And this, as we know, once we can have some sort of criteria, then we will be able to move on with doing clinical trials. So the cardiac MRI has really changed things, I think, for at least evaluating cardiac involvement. I mean, I tried to do cardiac MRI when I was doing pulmonary vascular disease, and we just couldn't figure out how to do it in a research standpoint, with exercising all of that. And that was 10 years ago. Now they do amazing things with these cardiac MRIs. And they've outlined, this is from a paper where it was outlined all the different manifestations. And now cardiac MRIs are really becoming quite common, and certainly much more easily, at least in the US, to get approved. And many of our patients are showing, even asymptomatically, having LGE and T2 and T1 markers and EBU, EBCs. So there's lots of things going on in the heart, and that's what we need to more characterize. So there have been early studies with cardiac MRI that showed that prospectively, that if you have an abnormal cardiac MRI, it resulted in a bad outcome. We knew that. And then there were several series of myocarditis patients that when you had this on MRI, you treated them for the myocarditis, then the myocarditis on MRI got better. But the recent study that Dr. DeLuca showed earlier today, I thought was really very interesting, where it took a group of patients that had abnormal MRIs, and then each of those patients were treated either with new immunosuppressive or additional immunosuppression, and they had improvement in their areas. Unfortunately, some of the improvements or most of the improvements were primarily related to the inflammatory myocarditis, and the LGE and the ECD really didn't do as much as I think we all would have hoped for, but maybe we're just not using the correct drugs. And so his lovely slide that I also included from his paper, where we really need to use the conventional cardiac treatment, and I think all of you are working with your cardiologists, and they're much more adaptive using all of that, as well as vasoreactive drugs. We don't really know. We tried years ago, again, to see whether vasoreactive drugs would affect the cardiac problems, and it's really hard to determine that. Maybe with the cardiac MRIs, we'll be able to do that. And then adding immunosuppressive agents, anti-inflammatories, different things, and potentially antifibrotics. I think this is, we have to figure out whether they're going to be helpful in cardiac involvement. So we've been fortunate through the years, particularly in pulmonary hypertension and pulmonary fibrosis, and getting other drugs approved. And in the past 2 years, we've had 3 drugs that have been approved that I think are going to be very helpful for our patients. Vonoprozin is a new potassium competitive acid blocker, and I guess it's been approved in Asia for a long time, but it was new to me this year. And it really, it's a once a day, doesn't have to be taken with food. It's it was comparable to full dose laser tracing in curing erosive esophagitis, but it had much better maintenance and longer maintenance. I can share with you that I've had many patients that have had refractory GERD, and this drug has really made a dramatic difference. Secondly, Neurodermalast, a new antifibrotic, has been approved for progressive pulmonary fibrosis as well as IPF. This is an inhibitor of PDE4B with both antifibrotic and immunomodulatory properties. And again, we see significant significant less loss in the patients that were treated with Neurodermalast compared to those who were treated with placebo. And this was a pure placebo study here. So this drug had previously been we previously had an antifibrotic, but it was so problematic with diarrhea. This new drug, Neurodermalast, is much better tolerated, and only 5% of the patients had to have a withdrawal from the study because of diarrhea. And it also had some really excellent secondary endpoints. With the most exciting one is that death was a positive outcome, which was, I think, surprising for this kind of one-year study, but it really was at least very exciting to me. So sotatercept, which is a new pathway for treating pulmonary arterial hypertension. It's a first-in-class fusion protein, IgG, linked to extracellular domains. It traps the TGF-beta superfamily members. And this was done as our most pulmonary hypertension in all comers, including scleroderma, so about 15% were connective tissue disease PH. And they were on background therapy, and they had to have increased BNP. So these were sick patients. The toxicity with bleeding and new telangiectasias has given many of us scleroderma people a little pause, but fortunately the toxicity with some nasal bleeds, some minor other bleeds has not been higher in scleroderma or really significant in scleroderma at this point. And the most important thing is, sick as these patients have been, they did have improvement even with having sometimes 3 other pulmonary hypertension drugs and 6 or 8 years of disease. They had significant improvement in their walk distance as well as their overall outcomes with less deaths and less hospitalization for progression of disease. So that's really another armamentarium to our treatment of a disease which used to be totally fatal, and now we've turned it into a very treatable disease. And lastly, as far as new things on the block, CAR T cellular therapy. 2 years ago, when Dr. Mays presented this, she said there were 5 trials listed on clinicaltrials.gov. Well, right now there are 52 trials. 46 of them are active. Actually, interestingly, 2/3 of them are in China. A lot of activity going on in China. But as of the moment, as of March 26th, there are only 14 cases officially completed and approved in the literature. And, there's some exciting improvements. And Dr. Khanna last October at the ACR meetings did review his experience with the BNS study. And it's a pretty typical CAR T, if you're familiar with CAR T studies. They have they take the cells out, and then they get treated with fludarabine and Cytoxan, and then they get the cells back. And then they're followed closely for 2 weeks in the hospital. The challenging thing is in oncology, those 2 weeks usually are filled with severe and sometimes really very, very severe different reactions, CRSs and icons. And these patients in this study that Dr. Connor, and you'll hear more about that study later on Saturday at the cellular therapy section. But these patients in this study were really had relatively mild CRS and were relatively easily treated, as well as the treatment of the ICANN, and all of them were reversible. So that gives us hope that our patients will be able to tolerate CAR T much better. So the early studies suggest that CAR T can be safe and reasonably well tolerated and manageable toxicity, and hopefully that will continue to be true. The preliminary outcomes, as we would suggest, and these are phase 1 studies, and they're relatively small to date, suggest improvement in skin fibrosis, joints, stabilization of lung fibrosis, and no progression of other organs. The challenges are who are the patients with refractory scleroderma, who and when to treat, and whether the benefits are maintained over a long term. So we really have a good ways to go, but it's really exciting with lots of studies and lots of outcomes to come in the coming years. So in summary, precision medicine is slowly improving with more antibody and biosimilar biomarkers in serum and skin biopsies, all which will help us guide to treatment in our future studies. While we have had significant progress in the treatment of lung involvement, both in ILD and PAH, recent work with characterizing primary heart disease, particularly with cardiac MRI and maybe even PET CT, will allow us to develop cardiac treatments specific for scleroderma. We will continue to benefit for treatment from general disease and scleroderma, ILD, and GI and PAH, but exciting times are ahead with many CAR T studies and other focused studies that are going to make a difference in scleroderma. Thank you.
Ginny, I want to thank you for your patience, and specifically I want to thank the audience for hanging in there.
Move to the last presentation, and it's really my pleasure to call the president of FESCA, Sue Farrington, to transmit us the voice of the patients.
So I am very, very aware that I am the last thing standing between you and a glass of wine, and clearly some people are so desperate for a glass of wine, they've got to go now. Okay, so this session asks, the title I was given for this session was, is it time, let's see if the clicker works, is it time to improve patient care through patient education? And to this question, I would say yes. Yes, it's always time to look at how we can improve patient care. However, I would also say that we shouldn't just focus on patient education. We first need to really look at the quality of the physician-patient relationship and the level of involvement that patients have in their care. And the reason is simple. There is a wealth of research and evidence that shows that when patients are involved in their treatment and care, the outcomes are positive. What the research shows is that satisfaction rises, motivation strengthens, and that leads to better adherence of treatment and self-care regimes. When patients feel that they've been listened to and heard, they're way more likely to become active participants. But this requires establishing the right foundation, one of trust, mutual respect, and understanding from the very beginning. So before we look at pushing out more information and more education of patients, we really need to look at how we involve and empower them and to create a way more collaborative partnership. I'd stress here that it's a partnership where each party brings their respective knowledge and experience to the table. But in this regard, we have a problem. And I've brought out 3 pieces of research done by your community that illustrate very clearly that we still have a problem. The first is a study done by, too fast. Oh, we don't have that. A study that was led by Cambridge University and King's College, London, which involved clinicians and patients with lupus, and showed that patient views and opinions are often considered to be of lower importance. Doctors were asked to rank 13 types of evidence used to diagnose neuropsychiatric lupus. Less than 5% were asking patients, they ranked asking patients for their self-assessment in the top 3. 46% of patients reported that they never or rarely ever had been asked their view. So what this means is that we are missing opportunities to spot and prevent a flare-up, and in other cases to hinder a more timely diagnosis. This quote from one patient really stood out quite starkly. I tell them my symptoms, and they'll tell me that symptom is wrong, or I can't possibly feel pain there or in that way. The result is the patient shuts down and valuable insight is lost. And I want to be really clear here. This is not about dismissing science. This is about integrating biology with the patient's biography to avoid misclues and diagnostic delays. It's about removing the disconnect between the learned clinical experience and the lived patient experience. And according to research conducted by Professor Denton, the systemic sclerosis community tells a similar story. The first piece of research revealed that involving and empowering patients in their healthcare often remains the exception rather than the norm. Analysis in a series of 20-minute consultations in 6 countries found that most consultations, patients were given little opportunity to explain their concerns or to ask questions. As a result, the opportunity to gain a joint understanding of the impact of the disease was limited, with both parties potentially missing important information. And it's not surprising that patients viewed these consultations as being quite negative and left them feeling alienated and excluded from decisions about their care. Further research undertaken by Professor Denton to explore communication needs and whether they were met showed that while prognosis and mortality were the main unspoken topics, many aspects of daily life were rarely discussed. Relationship, family, work, emotional well-being. By not having these wider discussions, patients expressed uncertainty and anxiousness about the future. In looking at what we need to do to improve the quality of the patient-physician relationship, research undertaken by Dr. Kana and Dr. Kwana identified a number of challenges that actually might hinder this proactive partnership, and I picked out a few. The first is conversation and power dynamics. A major challenge they identified was the style of conversation. The conversation where the physician controls the tone and flow, where there is a perceived lack of warmth and empathy and the use of over-technical and medical language. This is not patients saying this. This is research done by your colleagues. This style of conversation doesn't help to create an environment where the patient feels involved. The second was depth and complexity of information, which is not unusual with a condition like systemic sclerosis. And the need for this information can vary widely, depending on the patient and where they are in their patient journey. The third that we hear time and time again are time pressures. And the challenge with time pressures is that they push us to shorthand conversations and away from the topics that matter most to patients: family, work, emotions, and future planning. So how do we change things? And what do patients actually say they want? After many conversations with our patient community, 4 themes kept coming up time and time again. The first was active listening. Patients don't just want to list symptoms, they want you to understand their whole life with the disease. When you take the moment to understand the person behind the condition, their emotional well-being, their day-to-day challenges, how they're coping, you gain insight that no test can provide. But active listening isn't just about letting the patient speak. It's making sure that they know they've been heard, understood, and taken seriously. And this is really the foundation from which everything else rests. The second is about establishing a shared language. Patients and clinicians, we often use the same word, but we mean and understand different things. And a classic example that I've heard is the use of the term morbidity, which many patients hear as mortality. Confusion and anxiety then creep in. So using plain language and checking understanding isn't dumbing things down, it's levelling the playing field. Now, we're all guilty of this, and patients will often use Google, and they'll come up with technical terms that actually it sounds like they understand what they're talking about, but sometimes we don't. So establishing a shared language is really, really important from both sides so that we prevent any misunderstanding. The third is being honest, and that's a really difficult balancing act. As patients, we want clarity, especially about prognosis, mortality, and long-term outlook. As physicians, you want to be honest, but with rare complex conditions like systemic sclerosis, sometimes the honest answer is, we don't yet know. Patients may hope for definitive answers that simply don't exist. Clinicians may worry about giving information that's incomplete. The only way through is open, honest conversation about what we know, what we don't know, where we're heading, and what the milestones and potential setbacks might be. Honesty builds trust, even when certainty isn't possible. And then finally, respect for the lived and learned experience. Patients live with the disease every single day. As physicians, you bring years of training and scientific expertise. But both forms of knowledge matter. And both must be respected if we're going to reach more accurate assessments, earlier diagnosis, and more personalised care. As clinicians, you face real-world barriers: short appointments, limited tests, limited evidence in rare diseases. And patients often lack confidence to say what they really feel. This is exactly why lived experience must sit alongside clinical expertise, not beneath it. And I want to share with you a couple of quotes from clinicians. The first is from a psychiatrist. He says, people with chronic diseases really know their own body. Listening is most important. And if we don't listen, it's usually because we're afraid we don't know enough. The second quote is from a consultant pulmonologist, and he's saying what you all know, that early detection of PAH and SSC is critical. Patients often recognise deterioration before tests do, because they notice what they can no longer do, the simple things that they used to do with ease. These aren't patient advocate opinions. They're clinical insights from clinicians who've learned the value of listening deeply. But we all know that relationships don't exist in a vacuum. So what are the changes that we collectively need to champion to improve the situation? I've picked out 3. Measure what matters. We audit blood tests and throughput, but we rarely measure active listening or patient involvement. Relationship-centred skills are increasingly being recognised as clinical competencies. So we need to measure them, train for them, and reward them. We all know that you face insane pressures on your time. So the nurses and the multidisciplinary teams are pivotal, particularly for those topics that are left unsaid. Fears about the future, issues at home, and emotional well-being. We need to be working as a team, and we really need to harness this strength. The third is making better use of digital tools. We need to do this so that we can share information, we can improve access and support patients. Not to replace human connection, but to reinforce it. As you well know, medicine is complicated, and time pressure tempts us towards oversimplification. The take this and get better model. We know that doesn't necessarily always reliably deliver the best results. If we want better outcomes, we need better conversations. 2 heads are better than 1, but only if both are heard. I'm going to be giving you at least 5 minutes back so you can go and get your glass of wine. But before I close, I want to say a really big thank you to the patient community for their insight in helping to shape and inform this presentation. And I also want to thank Dr. Sloan, Professor Denton, Dr. Kana and Dr. Kwana for their research and evidence, shining a light on what needs to change within the clinical community alongside patients. Thank you.